Good morning. This is Romero, your chair of the ACIP voting members. Welcome this morning to the May 5th meeting of the Advisory Committee on Immunization Practices. We will be discussing rabies vaccines and dengue vaccine today, as well as a public comment session. So I'll turn this over to Dr. Cohn before taking roll. Dr. Cohn.
Thanks, Dr. Romero. And I ditto Dr. Romero's welcome to everyone. There will be no votes taken at this meeting today. This is information only to prepare for future considerations and recommendations by ACIP. Next slide. The next ACIP meeting will occur on May 12th, 2021. This is an emergency meeting, and we will have an agenda posted to the website soon. Next slide. For today's meeting, please, if you are on the Zoom line, mute your lines at all times unless you're called on for discussion. When Dr. Romero opens the meeting for discussion, please virtually raise your hand. And during the discussion period, Dr. Romero will take questions first from the voting ACIP members and then from ex officio and liaison representatives. Please disable your video, and there will be no votes today, so the ACIP members will not be on video. Next slide. This meeting's oral and written public comment process is designed to accommodate increased public interest in ACIP's work, maximize opportunities for comment, make public comment more transparent and efficient, and create a process for assigning limited public comment time. For this meeting, we'll be holding one oral comment session this afternoon. The oral public comment session will occur at approximately 1 p.m. Members of the public can also submit written public comments via regulations.gov using docket number CDC 2021-0025. Information on the written public comment processes, including about how to make a public comment, can be found on the ACIP website. Next slide. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Next slide. I am now going to pass the microphone over to Dr. Romero to take roll call. And before we start, I just want to thank our chair for taking the time to come to CDC to be in our very socially distanced space. And we are looking forward to getting back to normal in the near future and bringing all of our ACIP members in for our future meetings, hopefully not too long from now. Dr. Romero?
Thank you, Dr. Cohn. It's a pleasure to be here and to see all your smiling faces. So I'll begin taking roll, starting with myself present. Dr. Alt, please.
Yes, my name is Kevin Alt, and I'm an obstetrician gynecologist at the University of Kansas Hospital in Kansas City, Kansas.
And we also need to say, I'm sorry, that's also my fault. We need to also say that if we have any conflicts.
No conflicts.
Yeah. Thank you. Ms. Bata.
Good morning, Lynn Bata. I am the clinical immunization consultant with the Minnesota Department of Health, and I have no conflicts.
Thank you and welcome. Dr. Bell? Okay. We will skip Dr. Bell at this time. Dr. Bernstein?
Good morning, everyone. My name is Hank Bernstein. I'm a professor of pediatrics at the Zucker School of Medicine at Hofstra Northwell, and I have no conflict.
Thank you. Dr. Chen?
Wilbur Chen, adult infectious disease physician scientist and professor of medicine at the Center for Vaccine Development and Global Health of the University of Maryland School of Medicine. I have no conflicts.
Thank you. Welcome. Dr. Daly.
Good morning. Matt Daly. I'm a senior investigator at the Institute for Health Research at Kaiser Permanente, Colorado, and also an associate professor of pediatrics at the University of Colorado School of Medicine. I have no conflicts.
Good morning. Welcome. Dr. Fry.
Good morning, Sharon Fry. I'm a professor of internal medicine at St. Louis University with a specialty in infectious diseases, and I have no conflicts. Thank you.
Good morning. Welcome. Dr. Cotton.
Good morning, Camille Nelson Cotton. I'm at Massachusetts General Hospital, where I'm the clinical director of transplant and immunocompromised host infectious disease, and also at Harvard Medical School. My only conflict is that earlier this year I served on a data monitoring committee for a pneumococcal vaccine for Merck. I have no other conflict.
Thank you very much. Welcome. Dr. Lee.
Morning, this is Grace Lee, professor of pediatrics, Stanford University School of Medicine. I have no conflicts.
Good morning. Welcome. Dr. Long.
Good morning, this is Sarah Long. I'm professor of pediatrics and subspecialist in infectious diseases at Drexel University College of Medicine in Philadelphia, and I have no conflict.
Thank you. Welcome. Ms. McNally.
Good morning, Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Good morning. Welcome. Dr. Paling.
Good morning. This is Kathy Paling. I am professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine. I have no conflicts.
Good morning. Welcome. Dr. Sanchez.
Morning. This is Pablo Sanchez. I'm a professor of pediatrics, neonatologist, and pediatric infectious disease specialist at Nationwide Children's Hospital, The Ohio State University, and I have no conflict. Thank you.
Thank you. Good morning. Dr. Talbot.
Good morning. I am Kip Talbot. I am an associate professor of adult infectious diseases at Vanderbilt University Medical Center, and I have no conflict. Thank you.
Thank you very much. Welcome. I neglected to present my affiliations and conflicts. As I said, I'm Jose Romero. I am the Arkansas Secretary of Health and professor of pediatrics, infectious diseases at the University of Arkansas for Medical Sciences, and I have no conflicts. We'll move on to the roll call for the ex officio representatives. Centers for Disease Control and Prevention. Melinda?
Good morning. This is Melinda Horton. I'm director of the Immunization Services Division in the National Center for Immunization and Respiratory Diseases.
Good morning. Centers for Medicare and Medicaid Services.
Good morning. This is Mary Beth Hans from the Centers for Medicare and Medicaid Services.
Good morning. Food and Drug Administration.
Morning, Doran Finks from the U.S. Food and Drug Administration Office of Vaccines.
Good morning. Health Resources and Services Administration.
Good morning. This is Mary Rubin from Division of Injury Compensation Programs.
Morning. Indian Health Service.
Good morning. This is Uzo Chukwuman. I'm sitting in for Dr. Tom Weiser. I'm an infectious disease branch chief and the National Immunization Program Manager at the Division of Epidemiology and Disease Prevention at Indian Health Services.
Thank you for being here. Welcome. National Institutes of Health.
Good morning, John Weigel, National Institute of Allergy and Infectious Disease, NIH.
Good morning. Office of Infectious Diseases and HIV/AIDS Policy.
Hello, David Kim with OIDP.
Thank you. Welcome. I'm moving on now to liaison representatives. Let me begin with the American Academy of Family Physicians.
Good morning. This is Pamela Rockwell, Associate Professor of Family Medicine at the University of Michigan, and I have no conflicts.
Welcome. American Academy of Pediatrics.
Good morning. This is Bonnie Maldonado. I'm Professor of Global Health and Infectious Diseases at Stanford University, and I'm Chair of the Committee on Infectious Diseases for the American Academy of Pediatrics. I have no conflicts.
Good morning. Welcome. American Academy of Pediatrics Red Book.
David Kimberlin, Professor of Pediatrics, University of Alabama at Birmingham. I'm editor of the Red Book.
Thank you. Welcome. American Academy of Physician Assistants.
Good morning, Marie-Michelle Leger, Director of Clinical Education, American Academy of PAs, no conflict.
Welcome. American College Health Association.
This is Tavi Chai with UNC Chapel Hill with my co-liaison, Sharon McMullen with Cornell University, no conflict.
Thank you. Good morning. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. Welcome. American College of Obstetricians and Gynecologists.
Hi, this is Dr. Linda Eckert. I'm a professor of obstetrics and gynecology and an adjunct professor of global health at the University of Washington, and I have no conflicts. Good morning.
Good morning. American College of Physicians.
Good morning, sir. Dr. Jason Goldsman, Affiliate Assistant Professor at Florida Atlantic University, also general private practice in Coral Springs, Florida, representing the American College of Physicians. Pleasure to be here.
Good morning. American Geriatrics Society.
Hey, Dr. Ken Schmader here for ACIP.
Good morning. America's Health Insurance Plans.
Yeah, this is Bob Gluckman, Chief Medical Officer for Providence Health Plans. I have minor stock holdings in Abbott, AbbVie, Bristol Myers, Procter & Gamble, and Walgreens.
Thank you. Good morning. American Immunization Registry Association.
Good morning, Rebecca Coyle, representing ERA.
Good morning. American Medical Association.
I'm Sandra Freihofer, General Internist in Atlanta and Adjunct Associate Professor of Medicine at Emory, representing the American Medical Association.
Thank you. Good morning. American Nurses Association.
Morning, Chad Little, representing the ANA.
Welcome. American Osteopathic Association.
Good morning, Stan Graug, Professor Emeritus at Oklahoma State University, representing the AOA.
Welcome. American Pharmacists Association.
Good morning. This is Steve Foster, a professor at University of Tennessee College of Pharmacy.
Good morning. American Immunization Managers. Association of Immunization Managers.
Hi, this is Molly Howell, representing AIM and also the North Dakota Department of Health.
Good morning. Welcome. Association for Prevention, Teaching, and Research.
This is Dr. Paul McKinney. I'm professor of School of Public Health and Information Sciences, University of Louisville.
Good morning. Association of State and Territorial Health Officers. Officials, sorry. Association of State and Territorial Health Officials. Okay, we'll come back. Biotechnology Innovation Organization.
Phyllis Arthur, present.
Good morning. Council of State and Territorial Epidemiologists.
Dr. Christine Hahn, State Epidemiologist of Idaho.
Good morning. Canadian National Advisory Committee on Immunization. Okay. We'll come back. Infectious Diseases Society of America.
Carol Baker, here.
Good morning. International Society for Travel Medicine.
Good morning, Elizabeth Barnett here on behalf of the ISTM.
Welcome. National Association of County and City Health Officials.
Good morning, this is Matt Zahn, representing HO, present.
Welcome and good morning. National Association of Pediatric Nurse Practitioners.
Good morning, Patsy Stinchfield from Children's Minnesota, representing NAPNAP.
Welcome. National Foundation for Infectious Diseases.
This is Bill Schaffner at Vanderbilt, representing the National Foundation for Infectious Diseases. Thank you.
Good morning. National Medical Association.
Good morning. This is Pat Whitley-Williams, Professor of Pediatrics, Rutgers Robert Johnson Medical School, representing the National Medical Association.
Good morning. Pediatric Infectious Diseases Society.
Yeah, this is Sean O'Leary, Professor of Pediatrics at the University of Colorado, representing the Pediatric Infectious Diseases. Thank you.
Thank you. Welcome. Pharmaceutical Research and Manufacturers of America.
Good morning. Corey Robertson, present.
Welcome. Society for Adolescent Medicine Adolescent Health and Medicine.
Hi, good morning. It's Dr. Amy Middleman representing SAM.
Good morning. Society for Healthcare Epidemiology of America.
Good morning. This is Marcy Dries, Chief Infection Prevention Officer at Christiana Care, representing SHE.
Thank you. Welcome. Let me go back to the Association of State and Territorial Health Officials. Okay. That ends the roll call. We'll proceed to the first topic, which is rabies vaccine, with an introduction by Dr. Sharon Fry. Dr. Fry, please go forward.
Thank you. Good morning. The following presentation provides an update on the activities of the rabies work group. I would like to thank Ms. Lynn Bada, a rabies work group member, and Dr. Agam Rao, our CDC lead, as well as our liaison representatives and invited consultants for their hard work and continuing support. Next. This slide recaps our activities at the February meeting as they relate to PrEP. We addressed questions raised by the ACIP about PrEP costs, summarized clinical guidance presented at the previous meetings, and recap policy questions, evidence tables, and evidence to recommend frameworks. Additionally, the ACIP committee requested a fourth group to be added to the PrEP table so that persons with risk for rabies less than or equal to 3 years would be in their own risk category, and I'll show you in the next slide what that looks like. And we also voted on 2 PrEP questions, policy questions for persons greater than 18 years of age, and deferred the vote for persons less than 18 years of age to a future ACIP meeting. Next, please. So this is the new table, which adds the fourth group down at the bottom. And you can see for the first 2 groups, these groups include individuals with elevated risk for unrecognized and recognized exposure. The difference between those first 2 groups is that the risk of virus exposure is continuous in the first group and episodic in the second group. The third group has elevated risk of recognized exposure that is sustained. And for group 4, this group has elevated risk of recognized exposure that is not sustained. And this is the group that was requested to be added at the last meeting. And the last group, of course, is the population at large, which is at low risk of contracting rabies. Next slide, please. Since the last ACIP meeting, the work group continued to discuss topics related to PrEP and PEP. Specifically for PrEP, we discussed questions raised by the ACIP about rabies PrEP and children. We discussed communication of updates to the 2008 ACIP recommendations, including how, when, and through what channels to make these communications to stakeholders, and how to ensure communications are clear and can be smoothly implemented by end users. Specifically for post-exposure prophylaxis, we discussed which additional topics should be considered by the working group. For example, we're looking at immunogenicity in children and may look at immunogenicity in the elderly. Next, please. The work group's goal for today continues along the same lines. Specifically for PrEP, we will present the data review by the work group about PrEP and children, present 2 policy questions voted on during the February meeting for adults, and propose the same questions for children in anticipation of a vote during the June ACIP meeting. And specifically for PEP, we will provide background information about PEP and a general approach to PEP. Next slide, please. Here is an anticipated timeline. We just discussed what we're going to do today. Hopefully in June, we can vote on PrEP as it relates to children. We will also like to present information on RIG and PEP schedules. including grade and ETR, if the working group prefers to make any changes at that point. And then clinical guidance for any schedule deviations for PrEP and PEP, and may continue into October for some of those topics. Next, please. Finally, for today's presentation, all of which will be provided by Dr. Agam Rao, we will include rabies pre-exposure prophylaxis in children, background information on post-exposure prophylaxis, and what our next steps will be. Next slide, please. And thank you. And that completes that discussion or introduction.
Thank you, Dr. Fry. Dr. Rao, would you please approach to post-exposure prophylaxis?
Great, thank you, Dr. Fry. There are multiple levels to prevent human rabies in the United States, and some of these are listed here on this slide. They are avoidance of risky behavior, like avoiding international tourist destinations that are known to have rabid animals, vaccination of pets and wildlife, proper use of personal protective equipment when handling bats for occupational responsibilities. And over the course of a lifetime, the average person in the U.S. has no rabies exposure simply because these measures are in place. And so you see the average person gets needs no pre-exposure or post-exposure prophylaxis. But if those barriers fail, there's post-exposure prophylaxis, which involves rabies immune globulin and a 4-dose vaccine series. Prompt and appropriate PEP alone in response to an exposure is typically enough to save lives when an exposure occurs. But pre-exposure prophylaxis, or PrEP, is indicated for specific populations in the United States, and it does not negate the need for PEP if an exposure occurs. The ACIP does not recommend PrEP for the general U.S. population. It's given before an exposure, but does not negate the need for PEP if an exposure occurs and is indicated for only select populations and for specific reasons. There are 3 reasons that PrEP is recommended for select populations, and 2 of them are listed here on this slide. The first is that when rapid PEP administration is not enough, this can occur when someone is exposed to an extremely high concentration of rabies virus exposure or an unusual rabies virus exposure, like an aerosolized exposure. And these don't happen naturally. They would only really occur within a laboratory under unusual circumstances. The second one listed here is unrecognized rabies exposures. These can happen when, for example, someone who frequently interacts with bats and frequently feels them brushed up against them may not realize when they've had a bite from a bat, and that can go undetected. Here in this image, you can see a very small puncture wound there in the bottom figure. A bat tooth size is about 2 to 10 millimeters, and the bite strength approximately 2 pounds of pressure. So typically, someone would wake from sleep or recognize that they had this exposure, except as I mentioned earlier, when they are entering a high-density bat environment, like a bat cave, like a biologist might do, a bat biologist, and may not realize, may not find it atypical when they get swarmed by bats. And then finally, the third reason that PrEP is recommended for select populations is challenges with the access to post-exposure prophylaxis, or PEP. So RIG is not available in some developing countries. Rabies vaccines may only be available in the capital city of a developing country, resulting in a delay of PEP administration. And it's for that reason that travelers, particularly children, are recommended to get PEP. Now, these would be recognized exposures, and so the reason for PEP in this case is clearly different from the reasons listed on the previous slide. And this really is the main reason that children ever would receive pre-exposure prophylaxis. So this is a sequence of events illustrating what could happen to a traveler. Day 0 here, you can see that someone might arrive in the capital city of a developing country as a tourist. And maybe a significant time period after they've been there, they might have a bite from a rabid dog, but still within the capital city, and quickly get thorough wound washing with soap and water. And because they're in the capital city, they might have quick access to post-exposure prophylaxis. Now, PEP should be administered promptly, but there's no specified time period within which PEP should be administered after an exposure. For the sake of this figure, I listed the date of getting PEP as the day after the exposure occurred. At that point, because the person was in the capital city and may have had access to RIG and vaccine, they will have received that appropriate therapy and quickly and efficiently or effectively completed the entire series by day 45, which really is the ideal scenario. Now, where we run into problems, though, is where someone has an exposure in a more rural area, and for that reason, it takes, they only begin traveling to a major city where PEP is available the following day, and it can take a significant period of time, here listed as day 40, before they can actually identify a source for rabies vaccine, and there may not even be RIG available. And so obviously their care will be delayed. And so it is for those specific people for whom rabies PrEP is recommended. And the Yellow Book actually specifies that it should be recommended for travelers based on the occurrence of animal rabies in the country of destination, available of anti-rabies biologics, intended activities of the traveler, especially in remote areas, and the traveler's duration of stay. And children, the Yellow Book says, in particular, should be offered PrEP when indicated. And this here on the right side of this slide is a screenshot from the Yellow Book, which reads, children are at higher risk for rabies exposure and subsequent illness because of their inquisitive nature and ability to read behavioral cues from dogs and other animals. The smaller stature of children make them more likely to experience severe bites to high-risk areas such as the face and head. Also contributing to the higher risk is their attraction to animals and the possibility that they may not report an exposure. So this is all to say that clearly PrEP in children is an important issue for discussion today. The benefits of receiving PrEP is that no RIG is needed if an exposure occurs. Only a 2-dose PEP vaccine series is needed once an exposure occurs, and those are given on days 0 and 3 days instead of the 4-dose PEP rabies vaccine series, which is given at 0, 3, 7, and 14 days. And this can be helpful, as mentioned in the previous slide, when people travel to places where RIG may not be available, where the rabies vaccines may take time to access, and where a 2-dose series is easier to get than a 4-dose series because of travel itineraries and that sort of thing. So the work group clearly recognized that, as I mentioned, that children and rabies is an important issue. And so for that reason, they took the approach of even before considering a specific rabies pre-exposure prophylaxis series, setting some rules, I guess, for what they would consider acceptable in a pre-exposure prophylaxis series. So first, primary immunogenicity had to be demonstrated by a given series. That is, the minimum acceptable antibody titer threshold would have to be reached within 14 days of series completion. And then second, the work group determined that a high proportion of patients would have to achieve that primary immunogenicity. The rationale behind this first point was that if primary immunogenicity or seroconversion is achieved after completion of the vaccine series, and then an exposure occurs, there will be a rapid anamnestic response. And this anamnestic response would occur regardless of the time from PrEP to exposure. So as long as primary immunogenicity was reached, we could be confident that an anamnestic response would occur after an exposure. The work group felt that factors that do not impact an anamnestic response are those listed on this slide: the number of vaccine doses over that needed to achieve primary immunogenicity, the number of bites or scratches to a patient, the severity of bites or scratches, the location of those, and the size of the exposed person. Anamnestic response is an all or none sort of response that occurs quickly after an exposure, and that is why the number of vaccine doses to push the titer up higher than the minimum antibody titer doesn't contribute to the response. So then, recognizing that children are an important population for rabies PEP, the work group considered whether there is any reason to believe that children have a different response to rabies vaccines than adults. We performed a systematic review in 2019 to determine if pediatric response to various rabies vaccine series is inferior to that of adults, and we identified over 12 papers from multiple databases that met our search criteria. 7 of those papers involved children less than 2 years of age, and 7 involved children 2 to 17 years of age. The age ranges of the patients were 2 months to 17 years. And the work group's conclusions are listed here at the bottom of the slide, but I will, in the subsequent slides, explain this a little bit more. The conclusions were that the GMTs in children are the same or higher than those in adults for any given series, and that the GMTs stay higher for longer in children. And so there was no reason to suspect suboptimal immunogenicity in children compared to adults. So the next few slides are some of the manuscripts that we reviewed. I just want to point out a few key things on these slides. There are diverse ages represented in these manuscripts, and I'll be able to go into those a little bit in a little bit more detail. The first column of this table is the article. The middle column is some pertinent study details, particularly those items underlined in red. And then the final column is the conclusion from the paper. So this first study, the very first row, you can see it involved children less than 2 years of age. There were 68 subjects. The second one was children 5 months to 15 years of age. And then the third was children aged 5 to 8 years, and 703 kids were included. And in the conclusion column, I'll list just these few, but won't go into detail in the next few slides. The first one says, in comparison to 18 24-year-old subjects in Thailand studied similarly, these findings suggest that the immune responses of the toddlers were better than those of young adults. Evidence for long-term induction of protective antibodies by PrEP. There was good antibody response with titers higher than those in adults, and 100% of children had titers greater than 0.5 IUs per ml. And these are pretty representative of the papers in the subsequent slides. So on these next few slides, children aged 2 to 4 months, 84 kids, 240 kids in Vietnam, and in the last row, school-aged children, there were 206 kids. 2, 3, 4 month, and 1 year old, 72 children, 243 kids aged 6 to 17 years, 200 healthy children aged 12 to 18 months in Thailand, children aged 5 to 12 years, 190 school children. And I should mention that the reason that there's so many very young included in some of these studies is that the idea of introducing rabies vaccine pre-exposure prophylaxis into the routine childhood vaccine series was being considered. And then on this last slide, we have 400 school children, 175 school children, 6 to 13 years of age, and then 4 to 8 months at primary series and 16 to 20 months later on. And again, in the last column here, you can see 100% children had titers greater than 0.5, 100% had RVNA concentrations above 0.5, and then at the bottom here, all children mounted an amnestic response to challenge. So the work group really came away from this, I guess, convinced of the conclusions that have been made in the Yellow Book and also in the 2008 ACIP recommendations. That is why the vaccination schedule for children has not differed from those in adults. And the two images here are screenshots from the Yellow Book and the 2008 ACIP recommendations, and are referring to PEP, but the reasoning is the same. We have here in the top one from Yellow Book, in infants and children, the dose of HGCV or PCEC for pre-exposure or PEP is the same as that recommended for adults. And then clinicians should receive the same vaccine dose, i.e. vaccine volume, as recommended for adults. So after the work group confirmed that, the approach was that any pre-exposure prophylaxis schedule recommendations that were made for adults would be applicable to children as well. And we presented to the ACIP at the last ACIP meeting these two policy questions. Now, these are listed for persons, not just persons greater than or equal 18 years of age, but I'll read them the way that they originally phrased, even though they were only voted on for persons greater than or equal to 18 years of age. So the first one is ACIP recommends a 2-dose 0-7 days intramuscular rabies vaccine series in immunocompetent persons for whom rabies vaccine pre-exposure prophylaxis or PrEP is indicated. And the second was ACIP recommends an intramuscular booster dose of rabies vaccine as an alternative to a titer check for immunocompetent persons who have sustained an elevated risk for only recognized rabies exposures, i.e. those in risk category number 3 of the rabies PrEP recommendations table, which Dr. Fry showed earlier today. And the booster dose should be administered no sooner than day 21, but no later than 3 years after the 2-dose PrEP series. So the work group's thought process in developing this first recommendation is that the primary series, the 0-7 days IM series, there's robust data demonstrating the boostability for up to 3 years. The advantages for travelers, such as the children we're referring to, is that travelers typically do not have enough time to receive the third dose, the 3-dose series, because dose 3 is due no sooner than day 21. And often travel medicine clinic appointments are not scheduled far enough in advance to get that third dose. And so we know from the travel experts who serve on our work group that in many cases, they do not initiate pre-exposure prophylaxis because they cannot complete the entire series. And so the proposed recommendation is believed to facilitate more travelers getting vaccinated when it's indicated to do so. Now, we shared this information when we've presented the grade in the ETR in the past. I just wanted to highlight a couple key things. Oops. So this is the evidence profile. The grade assessment for the outcome of immunogenicity is measured by a titer at or above 0.5 IUs per ml. And we assess the body of evidence from RCTs and non-randomized studies separately, and concluded that we have a moderate certainty that is level 2 about immunogenicity for the RCTs, and there was 264 out of 264 people who seroconverted with the 0-7 days series compared to the 0-7, 21, 28 days, which also was 100% seroconversion. And really, we could have stopped at that because the certainty was level 2, but we did go forward and evaluate observational studies that we had identified in our search as well. And those are listed here on this slide. The ones highlighted in yellow are ones that involved children, or at least persons close to the age of children. We identified these 10 additional studies that compared a 2-dose to a 3-dose primary series. And I want to particularly point out the one study, Sabcharian study on the second to last row, where the mean age of the children was 10 and the range was 5 to 13 years of age. And 190 persons were included in the intervention. So this slide describes this a little bit better. After a 0-7 day series, 100% of the children had antibody titers greater than 0.5 IUs per ml. Only the bottom part of this image is relevant to this discussion with the HDCV vaccine that's used here in the United States. 100% of people had titers greater than or equal to 0.5 IUs per ml, and 100% had titers greater than or equal to 0.15 and 0.5, 100%. And the reason they included both 0.15 and 0.5 is that they estimated that 0.15 was close to the ACIP recommendation for the minimum antibody titer level. But as you know from previous presentations we gave, that the ACIP is planning to move towards the greater than 0.5 IUs per ml as well. So regardless, this study showed that appropriate titers were reached 100% of the time in these children. So the work group thought process for the second recommendation then was that there's every expectation from what we know about immunology that beyond 3 years boostability is preserved, but because rabies is nearly 100% fatal and the ACIP had advised us during previous meetings to ensure that there was robust data for any proposed change to the existing recommendations, we took the very conservative and cautious approach. We know from data that we've reviewed that the titer value at 1 to 3 years is indicative of long-term titer levels. And so a titer check and a booster, if that titer is under the cutoff at 1 to 3 years, would ensure long-term immunogenicity and provide that extra level of certainty. And additionally, since the titer level is going to be raised to 0.5 IUs per ml, we'd even more so be sure of ensuring high titers. But so as an option to that, though, we wanted to make sure, and as an option to titer checks, that a booster could be given instead of a titer check, because we realized that some people would prefer a booster dose. They would not want to get a titer and then just go, have to wait additional time to get that titer result and then get a booster anyway. And so that's why the booster as an option was proposed as the second policy question, the second proposed recommendation. And the fact that it's given as soon as day 21 is related to the current scheduling of the 3-dose PrEP series. So you could think of this as sort of a flexible 3-dose series if someone opts to go directly to the 3 doses of PrEP for persons at sustained risk for rabies. And then again, the evidence table for this showed there to be a level 3 of certainty. So in summary, we reviewed the primary immunogenicity of rabies vaccine in children, and there was no difference between primary immunogenicity in children compared to adults, including for young children, for any of the given schedules, for any previous schedules, for any other schedules. For the specific schedule that we proposed to the ACIP, we did have data from one observational study that involved the proposed PrEP series and U.S. rabies vaccine, and 100% of the children aged 5 to 13 mounted titers over 0.5 IUs per ml. And then as far as long-term immunogenicity goes, several of those same studies that we evaluated to understand rabies vaccine in children showed that titers in children may stay higher for longer. And since boostability is not a concern for adults, we concluded that it would not be a concern for children. The implications of not aligning the recommendations of children and adults was discussed by the work group, and the thought was that ACIP recommendations for PrEP have always been the same for children and adults. Now, if the adults, if there is this new precedent set, then adult travelers may get a 2-dose 0-7 days IM series before travel, and then a child traveler belonging to the same family may not have enough time for the 3-dose series and may not get vaccinated at all. And the end result would be adults will have received PrEP and children would not have received PrEP, even though the children are the population at higher risk. And so we, as a work group, are proposing the same two recommendations to the ACIP that were voted on and passed during the February meeting, but for persons under the age of 18 years of age, as you can see here listed on this slide. And again, that risk group number 3 is highlighted in red, just so that you can see which population we're referring to as the group who would get a booster as an option to a titer check. It's not people who would have limited risk for rabies less than 3 years. And I can take any questions about that. Thank you.
Thank you very much for another great presentation. This is open for discussion for questions. Dr. Sanchez.
Thank you, and thanks for such a complete explanation. I have two questions. One of them, on one of your slides, you had, and I think benefits of receiving PrEP. No RIP if exposure occurs, but you have 2-dose PEP rabies vaccine series. You said you put in 0 to 3. I think you mean 0 to 7 days, right?
Yeah, let me just pull up that slide. I think it is slide.
I don't have the number.
I have it actually right here. It is. Oh, it's slide 9.
Yeah, I don't have the number on it, but it's it starts with benefits of receiving PrEP.
Yes, it's the slide here. So it's 0-3 days is when someone would receive the 2-dose PEP series. If they had pre-exposure prophylaxis and then had an exposure, they'd only get the first 2 doses.
Okay. I'm sorry, I misunderstood that. And then the other one that I had a question on, in the Friedel study in 1984, you have that age, is it less than 5 months to 15 years? So how young did they go?
Yeah, I do see that on slide 14 that I've listed here, less than 5 months. I have that the range of the age groups I have was 2 months to 17 years of age. So on slide 13, the range of the children within all of these studies listed was age 2 months to 17 years of age.
Thank you.
Thanks.
Thank you, Dr. Long. Dr. Long, you may still be muted.
Failed my IQ test already. Thanks so much. A remarkable increase in data that you brought to us about children. I was sort of adding these things up. It looks like maybe even 2,000 children under the age of 18 years. The recommendation proposed, however, has no lower bound of age, as I understand it. And as I was just trying to add up those children that would have been under 2 years of age, for instance, I don't think I get more than a couple hundred. Can you tell us those? Can you ferret out from all those studies what the total number of children under 2 years or under 12 months of age were included in these studies?
Yeah, I could, I guess I would need to add up what I've listed on these slides. So maybe I could do that, or someone could help me do that, and we could get back to you with an answer.
Some of these, however, are, a broad range from
That's true.
under 5 months to 15 years. We really can't tell if there were 100 under 2 or if there were, 2 under 2. So I think that would be helpful if the proposal is for no lower bound of age. That would be helpful. And then the other question is the people from the American Academy of Pediatrics who are on the call. I'm hoping when we finish this part, Dr. Romero, you might call on them to see if they have had the opportunity to look at all this as they are focused exclusively on children.
Yes, Dr. Long. We actually have hands from Dr. Kimberlin from the Red Book and from Dr. Maldonado from the AAP. So they are coming up with their comments, I believe.
Thank you.
Thank you.
And Dr. Lung, in response to your question about trying to calculate out the exact number of people under the age of 2 years, I can do that for the next, for the June ACIP meeting.
Okay, thank you.
Dr. Kimberlin, please.
David Kimberlin, AAP Red Book. I want to thank CDC and the work group for, as Dr. Long said, a much more robust presentation about what is known of use of these vaccines in children. That helps me tremendously. I know that at the February meeting, I had raised my own personal concerns about that. And I also just want to sort of stress again what Dr. Rao said was a use or a way to consider this flexible 3-dose schedule where the booster can be given as soon as 21 days following the primary PrEP series of 2 doses, assuming this is extended down to children. And that as well makes me more comfortable compared with my issues that I, again, personally raised at the February meeting. So I want to thank you all very much for the thorough assessment and concise presentation made between last time and today, and then today for the presentation portion of it. Thank you.
Thank you for those comments. Dr. Maldonado.
Thank you, Dr. Romero. And I want to echo Dr. Kimberlin's personal statements there. But on behalf of the Committee on Infectious Diseases for the AAP, I also want to thank the committee and the investigators here for really addressing the concerns and questions that we as a committee had. We had a robust discussion at a recent committee meeting and really felt comfortable with the data as it has been presented, as well as bringing up the same issues around advising our pediatric providers regarding these new recommendations so that they're clear on our pediatric travelers. So I want to thank the committee for this added information. Thank you.
Thank you. Are there any comments, any other comments from the voting members or from liaison groups? I'm not seeing any. So again, thank you, Dr. Rao, for answering those questions that were brought up in the February meeting. And let's move on to the next topic. It's background and approach to post-exposure prophylaxis.
Thank you, Dr. Romero. So this is a background presentation, and so I'll start off by just explaining the basics of post-exposure prophylaxis. The components were mentioned during the previous presentation, but just to reiterate, this slide and the next few after describe what is involved in post-exposure prophylaxis. On this slide, a specific time point is indicated by days and is listed below the horizontal black line, and the vaccine or rig treatment for the specified time point is listed above the line. For persons who have not previously received PEP or PrEP, PEP in response to an exposure involves rabies immune globulin or RIG and 1 dose of vaccine soon after the exposure, which we call day 0. And then to complete the series, the patient receives 3 more doses of vaccine on days 3, 7, and 14, as shown on the right side of this slide. A previously vaccinated person is defined in the 2008 ACIP recommendations as a person who satisfies one of the 3 sub-bullets listed here. They're considered previously vaccinated if they received one of the recommended PrEP regimens of HDCV, PCECV, or RVA, all of which are cell culture vaccines known to be safe and efficacious. And then number 2, one of the recommended PEP regimens of HDCV, PCECV, or RVA, or number 3, another vaccine and had a documented rabies virus neutralizing antibody titer afterwards. The implications of being previously vaccinated on PEP management is that it eliminates the need for RIG entirely and also decreases the number of PEP vaccine doses, as we discussed during the previous presentation. You can see on this slide that someone who is considered previously vaccinated needs only to receive 2 doses of rabies vaccine on day 0 and day 3. And again, RIG is not indicated, and the number of vaccine doses shortens from 4 doses to 2 doses and is completed sooner. There are a lot of complexities that go into who should receive PEP, though, and the challenges of determining who should receive PEP is perhaps best illustrated by the large amount of PEP that is used in the United States to prevent human rabies. Approximately 55,000 people receive PEP each year in the U.S., and the impact of this is that there's unnecessary administration of vaccines. There's high costs associated with these vaccines and with rabies immune globulin in particular, and it's of course time consuming for patients to report for multiple doses of vaccine. There's emotional distress involved in a patient believing that they have been exposed to a high mortality illness and need to receive these vaccines in order to prevent death. And then there's less availability to persons who need it during vaccine shortage events, which has happened in the past. The 2 screenshots on the bottom of the slide are just 2 papers that describe inappropriate administration of PEP in the United States. They both evaluated whether the ACIP recommendations were followed and found that it was sometimes inappropriately administered. The study in the screenshot to the right was published in JAMA in the year 2000 and was a prospective case series study of patients presenting with an animal exposure-related complaint from July 1996 to September 1998 at 11 university-affiliated urban emergency departments as part of the Emergency ID Net. And the authors there found that in 40% of cases when PEP was administered, it was inappropriate, owing often to factors associated with an incorrect understanding of the role of rabies epidemiology in a clinician's decision about PEP. That same study also found that in 6% of cases, PEP was inappropriately withheld, again due to misunderstandings about circumstances for which PEP should be administered. So recognizing that it can be confusing for clinicians to know which exposures warrant PEP, Dr. Hunter, at a previous meeting over a year and a half ago, suggested to us during the Q&A session for one of our presentations that we consider outlining these considerations in the updated ACIP recommendations. And so the remainder of this presentation is an attempt on the side of the work group to do so. So before we do that, an understanding of rabies epidemiology is needed, and the next few slides explain some of the fundamentals. Human rabies is transmitted from infected mammals by a bite, scratch, or contamination of mucous membranes or an open wound with saliva or neural tissue. It's not transmitted by exposures to blood, urine, or feces, and so any exposures to those should not warrant post-exposure prophylaxis. There have been some rare cases after organ and tissue transplants, but the remainder of this presentation is focused on rabies after animal exposures. There are few animal species that are reservoirs for rabies. By that, we mean that there are few species that can sustain the circulation of rabies. Rabies virus variants, or RVV, are named for the animal reservoir species in which their circulation is sustained. RVVs are confined to geographically definable regions. However, it's important to understand that infection can be transmitted from the reservoir species to any other mammal and need not stay within the reservoir species. For example, the raccoon RVV can spread from a raccoon to a cat and then to a human. The specific RVV does not denote the animal to which the human was exposed, but rather the reservoir for that specific variant. The slide shows how in the eastern United States how raccoon RVV on the east coast of the U.S. could spread to various unvaccinated animals through bites. So what you see here, though, is the fact that the raccoon rabies virus variant caught hold in Florida. I'll explain a little bit more on the next slide. Spread within this species. The variant circulates among raccoons and then built up in this highly susceptible host population such that it was transmitted to individual mammals in a more resistant host population, which you can see here. And here, those more resistant host populations for the raccoon rabies variant are an unvaccinated dog, fox, or skunk, which could be exposed to a raccoon through a bite. So the host shift events can also occur with rabies. Cross-species transmission occurs sometimes all over the world, but nearly every time the virus dies out in the non-reservoir host. But occasionally the virus gains a foothold, and sometimes this is because the virus mutates and adapts to the new host, and sometimes the virus, though, gets lucky and finds a host that is genetically primed for viral circulation. And when this happens, it is referred to as a host shift event. Now, this is a hypothetical host shift event that could occur from raccoons to skunks, and so it's not a true event, but it's something that we actually do worry about. The last time that there was a host shift event was in the 1950s in Florida when a bat rabies virus shifted into the raccoon population, and it is the reason that we have the raccoon RVV here on the East Coast. This spread from southern Florida all the way into Canada and created what we call today the raccoon rabies variant in reservoir area, and is estimated that 75% of human and pet rabies exposures occur in this area, largely due to the interactions with animals infected with this viral variant. And so you can see how it's very important to understand the epidemiology. The map on this slide illustrates the different RVVs in geographic regions of the United States. Raccoon RVV is, as I mentioned on the previous slide, in the eastern part of the U.S. and is a result of host shift from bats. There are 3 skunk RVV delineated in brown, orange, and blue over here, and a result of host shifts from dogs or bats. And there are mongoose and fox RVV as well. So you can see that mammal reservoirs vary by geography. Terrestrial or wildlife rabies is due to RVV, for which wildlife are the reservoir. Non-terrestrial rabies is the RVV where bats are the only reservoir. Terrestrial rabies is restricted to the regions colored on this map. Non-terrestrial rabies is in all U.S. states except Hawaii, which is free of all rabies. And so an understanding of biogeography of rabies is essential to clinical decisions about whether a specific exposure warrants rabies PEP. For example, a bite from a raccoon in Washington state, there in the top left of this map, may be managed differently from a raccoon bite in Pennsylvania. One region has only non-terrestrial rabies, and the other has a whole lot of raccoon RVV. Fortunately, despite inappropriate PEP use in the United States, there still are relatively few cases of rabies in humans. For the time period of 2009 to 2020, there were 25 human cases of rabies among persons in the United States. 17 occurred due to domestic exposures and 8 occurred from international exposures. And the details are listed on the slide, but the main take-home messages are the ones here, that in domestic exposures, most were due to bats, and from international, most were due to dogs. A rabid dog has not been a source of human rabies after a domestic exposure for a very long time because canine rabies has been eliminated in the United States. And also none have been due to occupational exposures or in people who received pre-exposure or post-exposure prophylaxis during this time period of 2009 to 2020. Differing epidemiology in the 50 U.S. states is one of the reasons that drafting a one-size-fits-all PEP algorithm is challenging. Concern for an exposure in a terrestrial rabies region differs, as I mentioned with the Washington and Pennsylvania example, from that in a non-terrestrial rabies region. Rabies vectors and RVV differ by region, but also health departments in different regions of the country have differing management styles for these exposures. For example, in regions where Fox RVV, in regions without Fox RVV, 2 health departments can differ in their recommendation about PEP after an exposure. As another example, many but not all health departments advise against PEP for exposures to squirrels, chipmunks, and mice. But because some regions have had occurrence of rabid squirrels, for example, a general national algorithm advising against PEP after such an exposure would be too simplistic. The differences in health department guidance are impacted by the degree of oversight and case management of animal bite investigations from the health department. Guidance on their website can vary as well, and some provide detailed and complex algorithms recommending or not recommending PEP depending on various characteristics of the exposure. But others provide limited online guidance and recommend consulting the health department for case-by-case advice. The comprehensiveness of this online guidance can also differ. Some of them omit guidance about caged rabbits and hamsters and other so-called pocket pets, but some provide a very long list of animals that could be risky. And since health departments really are an incredible resource and a huge source of thorough details about the local biogeography, creating some national algorithm would overstep and result in confusion because some health departments provide more information than others on their websites, and when they don't provide it on their websites, expect one-on-one consultation. So beyond rabies epidemiology, there are other issues considered by health departments when advising against PEP, and we took those into consideration in addition to the expertise that the health departments have about local rabies biogeography and the benefits of a general framework, so that clinicians could understand what factors should be considered before giving PEP. And the next section of this presentation was our attempt to balance the two. So we tried to balance providing some sort of general framework for the clinicians so that they realized what factors were important, but also not providing too prescriptive guidance, since there's a lot of nuances that go into a decision about whether or not someone should receive post-exposure prophylaxis. And during the question and answer section after this presentation, I'd be very interested in hearing your input about whether or not it is of value, given that we had to straddle these two issues. And now I'll present the approach to post-exposure prophylaxis. Our objective here was to enable clinicians to handle easy cases quickly and not to contact the health department if things were very easy. Defer to the health department, though, for guidance for the most definitive answers, and the consultations with health department are known to decrease the odds of inappropriate PEP administration by 87%. And so taking that away would not be a good thing. But we wanted to outline the multiple considerations needed for decision about PEP depending upon the exposure type. So we wanted clinicians to be able to collect the important history before the health department consultation, to understand the factors that weigh into the decision and participate in the decision making, and for clinicians to better be able to counsel affected patients. And so that was what we sought to do, even though we couldn't be too prescriptive about whether or not PEP should be administered for different scenarios. So So the 2008 ACIP recommendations outline the things listed on this slide as the considerations when making a decision about whether or not to give PEP. So whether or not it was a bite or a non-bite exposure, the type of animal to which the exposure occurred, whether it was bats, domestic dogs, cats, and ferrets, or wild animals. Local animal rabies epidemiology, which we just covered, is a critical part of deciding whether or not PEP should be given. And then the circumstances of the biting incident, whether it was provoked or not provoked, the behavior of the animal, and the vaccination status of the exposing animal. This table is directly taken from the 2008 ACIP recommendations. In the first column are specific animal types, and the second are ways that the animal, if responsible for an exposure, can be evaluated. And the third column is the PEP recommendation based on that evaluation. So here in the first row here, dogs, cats, and ferrets, the recommendation is when an exposure occurs to one of these, that they be observed, that they're healthy and available for 10 days of observation. If they show atypical behavior or if they are suspicious for having rabies, then immediately begin prophylaxis. If they're healthy for that 10-day period, then there's no need for prophylaxis. And if the animal escaped entirely, the ACIP recommendation says to consult public health officials. Now, for skunks, raccoons, foxes, and most other carnivores and bats, these are regarded as rabid unless the animal is proven negative by laboratory testing. And the ACIP table here just says consider immediate prophylaxis and doesn't provide too many details beyond that in the ACIP recommendations. And then for livestock and small rodents, like rabbits small rodents, it says here that rabbits and hares are rodents, but that's an error. And then large rodents, woodchucks and beavers and other mammals. These are considered individually according to the ACIP recommendations, and public health officials should be contacted for these according to the table here. Bites from squirrels, hamsters, guinea pigs, gerbils, chipmunks, rats, mice, and other small rodents, and rabbit and hare almost never require anti-rabies post-exposure prophylaxis, but the ACIP recommendations do not explicitly say that PEP should not be given when those exposures occur. So we took all of that into consideration, and we tried to draft this figure here. And I'll go into it a little bit more detail, but again, the intention was to balance the importance and the value added by health department consultation or information on the health department website that is specific to the local biogeography, with the clinician understanding better what factors are important to making a decision about whether post-exposure prophylaxis should be given. And I will explain it in a little bit more detail. And as I mentioned, we are seeking feedback on whether or not you think it is of benefit after I finish. The first column here, at the very top in the blue box, a patient reports contact with an animal in any of the 50 U.S. states. If that answer to that is yes, then you move forward into the second blue box, and it says, was the animal a mammal and exposure that can transmit rabies? And now if the answer is no to that, you can see on the far right that you fall into the do not give PEP section. And this would mean bites from reptiles or exposures to urine or feces of mammals would end up in the no column and not receive PEP. Now I'll go over each of the other 6 columns here for dog, cat, or ferret, bat, wildlife, livestock, cage rabbits, rodents, or pocket pets, and the squirrels, wild rabbits, chipmunks, etc. in the last column, and explain what we drafted here. So in the first column is the approach to exposure from a domestic dog, cat, or ferret. And what we listed here is consult the health department website for state-specific guidance. And if the website itself does not provide the information that the clinician needs, they could consider consulting the health department by phone with the following information. And all of this is information that would help the health department advise the clinician, and also the clinician would be armed with an understanding of why the health department recommended what they did and could counsel the patient accordingly. So the items here is the animal available for observation. So that hasn't escaped and is actually owned by someone. Was the animal exhibiting unhealthy or abnormal behavior? Was the exposure provoked? Were the patient injuries severe, like multiple bites or very deep ones? Where anatomically were they located? Head and neck, for example, can be riskier. And was the animal up to date on rabies vaccinations? And all of the answers to all of those would help with the consultation with the health department website or with the health department directly. Now to the second column about bats. So bat exposures can be challenging to assess. They're the most common RVV that causes human rabies in the US, and as we've previously covered, the risk can be difficult to assess because of limited injury from a bat bite compared to terrestrial animals. Bats involved in potential human exposures should be caught and tested when possible, and the patient should be interviewed to determine if the bite, scratch, or mucous membrane exposure could have occurred from that bat. Bat in a room is of concern in specific situations. If someone is a very deep sleeper and they awaken to find a bat in the room, or if an adult witnesses a bat in a room with a previously unattended child or a person of altered mental status, then those might also be reasons to err on the side of post-exposure prophylaxis, and an intoxicated person as well because of altered mental status. But the average person should actually wake after a bat bite or a bat exposure. And so what we drafted here was that if the bat is available for testing, then the health department website should be consulted, and the health department is typically contacted because they can facilitate the testing. If the bat is not available for testing, then it should be presumed rabid and post-exposure prophylaxis given straight away. And then the questions we list here that the health department would want to know are the wounds severe or to the head and neck? Was the exposure unprovoked? Example, a bat bite while sleeping. And is the mammal available for testing? And along with the health department, the clinician may make a decision about how quickly the laboratory testing might return, and if there is some sort of delay, they may consider giving post-exposure prophylaxis while awaiting the results of the tests. Next, we have here wildlife, and wildlife is a very large group, and so this one is particularly hard to be general about. The wildlife's a diverse group with different animals being of concern for different regions in the country. Some health department websites, as previously mentioned, have a lot of details about specific animals, while others do not. And so we erred on the side of being general and simply lumping them in as just wildlife, and including the questions listed here, whether the wounds are severe to the head and neck, whether it was an unprovoked exposure, if the animal is available for testing, again, the turnaround time, and if it was to wildlife, a discussion with the health department about whether or not this was in a terrestrial rabies region or a non-terrestrial rabies region, as that has a strong role in determining whether or not the health department recommends PEP. And then on to livestock now, which is the fourth here. Consult the health department website for state-specific guidance. If more guidance is needed beyond that, you can contact the health department directly. We were very general here because some health departments like to coordinate the investigation when a livestock is suspected, and they are really the ones who would be the experts at assessing the behavior of the animal to know whether or not it is atypical. A clinician really wouldn't be able to determine that. And so depending on that assessment, there might be a decision along with the health department about whether or not PEP should be administered. On to caged rabbits, rodents, or pocket pets. So the health department website again should be consulted, because some health department websites are very particular, very specific about what to do in these situations. And the clinician may get all the information they need from their health department site. Some questions to ask, though, if the clinician does decide to contact public health, is whether the animal was exhibiting atypical behavior, and for pets, whether the animal was exclusively caged indoors. And if so, was there any opportunity for exposure to a rabid animal like a bat? And that will help the health departments make a decision along with the clinicians. So Exposures outside of the 50 U.S. states, though, are more challenging. There's 30 known reservoirs for rabies worldwide. There's mongoose, there's dog and canine rabies endemic regions, bats outside of the U.S., monkeys, all kinds of exotic animals, like, for example, the Australian dassy, which is found on Table Mountain. And so it's very difficult to actually be at all prescriptive in and put together any kind of algorithm for those cases. And so our work group then concluded that the guidance for those situations would be to consult the health department for case-specific advice and collect information about the type of exposure, whether exposure was provoked or not provoked, and the behavior of the animal, and take those cases directly to the health department for case-by-case consultation. So in summary, we determined that determining which human exposure necessitates PEP can be very challenging. The health department has a critical role in these consultations and is available, including during off hours, for consultation about these complex cases. They really are the experts in local biogeography and also are the ones who can facilitate laboratory testing and animal observations if needed. But at the same time, just based on feedback we got from previous ACIP meetings and from some clinicians, some sort of framework or some sort of general algorithm could be useful to clinicians. It would not replace the nuanced advice from public health veterinarians that is listed on their websites or that you may get through one-on-one consultations. But the work group thought it might still be of some benefit to provide this general guidance. And I guess that with that, we were hoping to get feedback from the ACIP, given it's not maybe the most ideal algorithm. And the work group was somewhat split, actually, about whether or not it really was helpful or not. So I guess with that, I'd love to take any feedback on that.
Once again, thank you for a wonderful presentation and for expanding my knowledge of animals. I had to look that dassy up. Very good. Are there any questions from the working group? And could we also go back to the flow chart or flow scheme at the very beginning, so we can throw that up there?
Yep, that's slide 20.
Okay. So let me open it up with a question that I frequently encounter. So under number 1, the dog, the cat, or the ferret, the question is the animal available for observation? And it is not uncommon where I'm from, where an individual has dispatched the animal out of anger or fear or whatever, is the question also specific for, is a carcass available? Okay, good. So I'm seeing a head nodding over here. So that refers to not just the animal itself.
Yes. Yes, if an animal carcass is available, then that can be tested. The health department can facilitate that testing. Okay. In the case of bats, that's typically what happens. Yep. It's a carcass.
Okay, Dr. Daly.
Yeah, thanks for that presentation. The algorithm, I mean, I think when you walked us through it, it made a lot of sense, but my question is whether you feel like it addresses some of the issues that came up with inappropriate post-exposure prophylaxis. So reflecting on what those sort of circumstances were, would this algorithm help?
Yeah, so a lot of those situations were ones in which people didn't know that local biogeography was important to deciding whether or not someone should get post-exposure prophylaxis, didn't realize that they should consult with the health department, didn't know that a provoked versus unprovoked attack changes the situation. And so we thought that outlining the specific questions here would enable the clinician to refer to the health department website and see if there's more detailed information, or consult the health department directly. And I'll give you an example is squirrels, for example. A lot of people will give post-exposure prophylaxis for squirrel exposures, for squirrel bites. And unless the squirrel is actually rabid behaving, it really probably is not necessary. And some websites, some health department websites will straight out say it's not indicated for a squirrel, whereas others that have had experiences with squirrels. I know there's a health department on the East Coast, there's a couple, but there's one in particular that was telling us that they've had instances where squirrels have chased people and are known to be rabid. And so those situations would clearly warrant PEP. And so that's why we do believe that it would cut down on all the unnecessary squirrel PEP that's administered if people did follow this and consult their health department.
Okay, thank you.
Dr. Paling.
Yes, thank you for a wonderful presentation. And I did want to respond and say I do think that this additional information is helpful. In my experience, some of these questions come in at midnight, 1, 2 in the morning when not everybody's answering phone calls. And so it is very helpful to at least be able to get through the night on this. One thought I have is it seems like for every single algorithm, consulting the health department website for state-specific guidance is universally true. And maybe if we had that across the board, that would be helpful and to highlight that important role.
Yeah, no, that's a good point. Thank you so much for that advice. It's a good idea. We certainly don't want to trump the health department's advice, and so including something like that for every single category makes sense. So thanks for that.
Dr. Long.
Thank you so much. You said there was some differences of opinion among the work group. I have a difference of opinion among myself. It's very, very difficult. And I wonder if, first of all, there are websites, and so many that I have looked at wouldn't be terribly helpful. And so we, as infectious disease doctors, get called both from primary doctors who have or have not looked at the website and ask the definitive answer of us. And we sometimes get calls from the doctor who has spoken with the health department, and now the health department has almost always said yes, and the doctor really doesn't think it's indicated. So the decision not to give post-exposure prophylaxis is the very difficult one. So my question really is, you said that in one place that something decreased by 80-something% inappropriate use. But how much inappropriate use is there? I would say that we ought to be able to figure out the obvious inappropriate use, urine exposures, et cetera. But after that, how much differentiation is there really that allows you to say no in all of this very complicated algorithm? So can you give us a sense of, if we very carefully define inappropriate as something that everyone would say would be inappropriate and it's not circumstance related, all the circumstance related ones are probably difficult but never inappropriate because you just can't very frequently say no. Very, very frequently you just can't say no. You can't just say no. That's what I should have said. I'm sorry. It's been a complicated question. Do you think you sort of understand my question?
I do. Thank you for that question. I think so. I can give you an example. There's a lot of times, and I think it's mentioned in those papers as well, where the animal was actually available for testing and could have been tested, but post-exposure prophylaxis was initiated and the animal was never tested. So that's an example where understanding that testing of the animal might rule out rabies and remove the need for post-exposure prophylaxis entirely. That's an example of a situation where inappropriate use could be streamlined. So there are situations like that too, like the squirrel example I provided, where if the animal was not behaving strangely and someone walked up to the squirrel and agitated it, then the fact that it bit the human is probably not unexpected and might have the clinician err on the side of not administering it. It'll also arm the clinician with enough information after consulting with the health department to make a decision for their patient in front of them. Like, for example, if that patient is paying out of pocket, if that patient has, isn't worried about that squirrel because they know they agitated the squirrel, then that patient may choose something different from from another patient who is anxious about it. So I guess when I think inappropriate, I think of situations where the animal was available for testing, the animal was available for observation, or the animal is really unlikely to have been a source of rabies and was probably provoked.
Dr. Talbot.
Yes, this has been a great presentation and it has highlighted the complexity of this. I just wanted to make a quick comment that I am much less worried about overuse of prophylaxis than I am underuse. So whatever flow diagram or chart or recommendation we would make, I would always think that we would want to err on the side of caution since this is a fatal disease and it is preventable. And so, yes, it's okay to test the animal, but if you're not going to get hold of someone for 48 to 72 hours, it's okay to start prophylaxis and then maybe stop it if it's not appropriate. But I think we really need to be more aware of underuse than overuse. Thank you.
Thank you.
Thank you for those comments. Are there any questions or comments from the liaison or the ex officio members? Dr. Zahn.
Yeah, thank you, Dr. Romero. So I use just one comment as a member of this work group. I tremendously appreciate Dr. Rouse working through this and all the work she put into this. I guess, so I'm not an East Coast public health person, I'm a West Coast public health person. And so my experience is, just for example, with the squirrels and mice, there just hasn't been any evidence of transmission from squirrels or mice to humans, existence. And, the difficulty with this algorithm as I look at it is, as a provider, if you read this, you'd say, well, talk to public health about state-specific guidance or local-specific guidance. And they call me about a squirrel bite and say, was the squirrel exhibiting atypical behavior? Well, what's typical for a squirrel or not typical? That can be tough to tell. Was the animal indoors or outdoors? What's a squirrel? So it's outdoors. So would I recommend prophylaxis? The answer to that would be no. Why would I recommend it? Not because of local, epidemiology or surveillance of squirrels. It's my assessment, honestly, that the risk is extraordinarily low and I wouldn't recommend that. And that's just what I've recommended. I think I'm not the only local or state person who's recommended that. If you look at this flow diagram, the difficulty here is that it kind of gives, to me, it gives the impression that we really should be thinking through every white squirrel, mouse, or wild rodent bite. And to be honest, I just don't think that's the case from that, what we've seen, existence, epidemiology. And so I do worry that this, and at least in certain circumstances, complicates rather than simplify guidance. I think I appreciate very much the work group, certainly Agam putting this together. I think if providers really think it helps, then I think that's worth considering. But certainly on the public health side, I do worry about complicating rather than simplifying messages.
Yeah, thank you, Dr. Zahn. So Dr. Zahn, as he mentioned, is a member of the work group and certainly was expressed that view on the meetings, and the people who were dealing more from the clinical side of it thought that it would still be of value. So that is exactly the sort of feedback that we would love to hear from other ACIP members and liaisons, whether or not the benefits outweigh the cons, or whether or not we'll create unintended consequences where health departments are inappropriately consulted for every squirrel bite.
Thank you, Dr. Rockwell.
Hi, thank you. I'm speaking now as a clinician, a family physician who often gets questions from patients. I think this is extremely helpful to, especially me here in Michigan, it would be probably squirrels as the issue, to help us to go through this algorithm. And I, for one, did not know that squirrels were really not a high-risk animal until today. So maybe this algorithm can be nuanced a bit to avoid over-treating, if that's possible with the word. but I find it very helpful as a primary care physician.
Thank you for those comments. Dr. Bernstein.
Yes, thank you. You've done a wonderful job in presenting important and detailed information about life-saving steps. I do wonder whether the algorithm to me looks a bit complex as a rabies decision support tool. And I guess there's not enough rabies cases or inquiries to have a live call line like the poison control line that exists now. But I wondered whether would an automated telephone decision support tool be an option and be helpful and readily accessible for patients, families, and providers.
Yeah, so Dr. Zahn, I'm sure, could speak to this, but rabies consultations are probably one of the most common consultations that health departments get, local health departments, state health departments, and I know we at CDC also get a lot of rabies consultations for specific cases. So there's sort of already is that sort of service, and the specific websites, the state health department websites, we actually reviewed all 50 of them, and some of them really do provide extremely nuanced, like yes or no, sort of, that's how clear it is, where it says, can the animal be observed? Yes. Observe for 10 days. If the animal is not exhibiting signs of rabies, then no post-exposure prophylaxis. If the animal is observed and yes, they are showing atypical behavior, then start post-exposure prophylaxis at that point and have the animal tested at the health department. So some of the websites are just so detail-oriented that the answer could probably be obtained without even calling the health department. And for others that have opted to actually handle these on a case-by-case basis, that seems to be their preference, and so I guess I believe, and maybe I'll ask Dr. Zahn to speak, or someone else, Dr. Romero, to actually speak about whether or not that is the right thing to do.
Yeah, I'll welcome Dr. Zahn's comments, but also I'll offer you, as the director of the health department in Arkansas, we have a veterinarian who is specifically tasked with getting these calls, and she gets a lot of these calls from rabid skunks and from people that have dispatched the skunk and then have handled the carcass. And so we have, at least our state, has a specific person that answers these questions and can be called, unfortunately, any hour of the day or night to answer these questions. And generally, we tend to refer these from the emergency room overall for her to adjudicate the exposure. Dr. Zahn, I see your hand is up. Do you want to offer some comments?
Yeah, no, I mean, I think Dr. Romero, you covered it very well. I think to me this algorithm to me really emphasizes the tremendous importance of having state and local, guidance that's available, that's easily available, that's complete, and that's useful for providers. That's an absolute necessity, and certainly state and local health departments look at it as a responsibility to be able to respond at any hour of the day or night. So.
Yeah, as a final comment, a lot of this is really local epidemiology. I mean, where I did my fellowship, there were reports of rabid skunks in the park. Rabid squirrels in the park, and so the consideration for prophylaxis in that setting. But where I am now, we haven't had that issue. So it really is local epidemiology. Are there any other comments or questions?
Jose, this is Bill Schaffner. I have my hand up, I thought.
Oh, I'm sorry. It's not showing up here. Forgive us if we did. For some reason, it's not working. Go ahead, please. Chime in anytime.
Thank you. Yeah, well, thank you very much. And let me add my words of appreciation for this very thorough and elegant presentation, Dr. Rao. Along with my colleagues, I'm just beginning to work my way through this algorithm, and my thinking is along the lines of Drs. Long and Talbot. Forgive me for just picking up one thing. I'm looking at the bat exposures. these are the kinds of calls that I used to get most frequently. And I was wondering, oughtn't these questions lead us to whether or not post-exposure prophylaxis ought to be given? And let me just ask you, are wounds severe or to the head and neck? Well, that helps us understand the nature of the exposure, but I was under the impression the location or severity of the location of the exposure on the anatomy didn't determine whether you ought to give prophylaxis. So I was wondering why that was there.
Yeah, no, thank you for that question, Dr. Schaffner. So the reason it's there is that if the bat is available for testing, so if the answer is yes, then you're going to be calling the health department to provide additional information and to provide the bat for testing. If the wounds were severe and to the head and neck, you may, even though you have the bat for testing, decide to proceed with post-exposure prophylaxis while that testing is taking place. Whereas if it was maybe non-severe, if it was a non-provoked bat exposure where you were hitting the bat and that's why it bit you, those sorts of things might push you towards waiting until the laboratory testing is completed. Yeah, that's actually happened to us quite a lot, where if a person gets bitten while they were asleep and the bat is available for testing, should the PEP be started right away, or how much time is it going to take for that testing to come back? Is it only going to take 1 day? Is it going to take 6 days? And that could make all the difference for the patient. And so that is part of why it's listed there, so that the health department and the clinician can together make a decision about how urgent PEP should be given.
I hear you. And I guess some of us would have a lower threshold for administering post-exposure prophylaxis than others. And that's just one of the reasons this is very, very complex.
Yes, thank you.
Dr. Zahn, your hand is up. Is it a leftover or a new question?
Yeah, I apologize, Dr. Romero. I do have one more comment, which is regarding post-exposure prophylaxis. There's giving vaccine and there's giving immune globulin. And immune globulin is not necessarily cheap and always is not necessarily available. And so I do recognize, obviously, 100% fatal disease, so you certainly don't want to undertreat. On the other hand, there is a resource and financial reason to, at least have good reason to use post-exposure prophylaxis. It is something that I think it's important that there's good guidance and people use, full reasoning before we do use those resources.
Thank you very much. Dr. Sanchez.
Yes, thanks. So that was a great presentation, and really, I think it is needed. The guidance. I agree that that over-treatment or over-prophylaxis for a disease an infection that is fatal, I do very much understand, and of course, and I've done it as well in terms of recommendations. I do think that ultimately this algorithm needs to be a little bit refined, and I agree with previous comments that it seems like for all of them we consult health departments. So I think there's some guidance, and like even with the bat one, are wounds severe or to head and neck, it still takes you just to risk assessment and patient-specific factors. So somewhere it also needs to say that you may want to initiate post-exposure prophylaxis earlier for some of them. So I think it needs a little bit of tweaking to be really useful at the primary care level. But I think it's a great guidance ultimately, because we do need it.
Thanks, Dr. Sanchez. One reason, and we'll have to deal with the nuances, but one of the reasons that we didn't include consult health department at the very top of this was the bat situation that you just mentioned, where if the bat's not available for testing, then you don't need to actually consult the health department, and you go straight to is the bat available for testing? You go straight to give PEP. Without any need to consult the health department. But that's the only exception to all of these mammals, where for every other mammal, the first step is to consult the health department. So we'll work on trying to make it less busy and a little bit clearer to follow and do our best. So thanks for that. Thanks for that advice.
A little more user-friendly, basically.
Thank you.
So that's great.
Are there any other questions? I'm not seeing any hands, but if anybody else is having a problem getting their hand up or I'm not seeing, please, you can ask your question now. Okay, so next steps, turn it back over to Dr. Rao for next steps comments.
Great, thank you very much. So this presentation will be relatively quick. It's just to show the work group's directions and what can be expected in the next ACIP meetings. Okay, so you've already seen this slide when Dr. Fry presented it earlier. Today's meeting was intended to finish discussions about PrEP by presenting information about children and to begin the PEP presentations. And so for next month's presentation into the October presentation, we are planning to have propose a vote on the two PrEP questions for children, and also to present the work group interpretation of data about RIG and also about the PEP schedule. And also a lot of clinical guidance issues that we've identified as issues that are frequently asked of health departments and of CDC and could be clearer in the ACIP recommendations. So ongoing work group discussions involve the things listed on this slide. So as far as rabies immune globulin go, during the next meeting, we plan to present information about this. There's some newly licensed RIG products since the 2008 ACIP recommendations came out. There's also internationally a lot of discussion about the location of RIG administration, and WHO actually changed their recommendations during their most recent update to limit RIG administration to just infiltration around the wound and to not give the remainder intramuscularly. And so the data surrounding those issues are topics that the work group has been discussing and will be presented at the next meeting. Onto the PEP vaccine series, the number of vaccine doses is something that is constantly being evaluated, and WHO on this front as well shortened the number of PEP vaccine doses from a 4-dose series to a 3-dose series. We on the work group are aware, though, that the considerations for ACIP will be different and that there's going to need to be a lot of robust data to confirm long-term immunogenicity, since PEP is used as the equivalent of pre-exposure prophylaxis for any subsequent exposure, and would need to be boostable if it was given years previous to an exposure so that the patient could only get a 2-dose vaccine series. And so we're trying to evaluate the available data so that we can bring our interpretation to the ACIP at the next meeting. There's also a lot of clinical guidance topics, as I mentioned, that have been discussed and that will be presented, and hopefully change the wording or the phrasing of some of the guidance that's in the ACIP recommendations. Some of that guidance is listed here on this slide and includes PrEP and PEP schedule deviations. PEP initiated abroad, for example, if it was administered intradermally abroad and initiated abroad but not completed there, with a vaccine that's not available in the US or according to a schedule that's not outlined by ACIP, how to deal with those situations. And then excessive RIG use is something that we know happens where someone inadvertently gives a very high dose of RIG, and the implications that can have on rabies antibody titers is a frequent question that we get asked. And then finally, there's a theoretical concern that if someone is showing signs of rabies and gets post-exposure prophylaxis at that time, that there could be detrimental effects from that, but it's somewhat unclear. And so these are all issues that we are evaluating so that we can modify the wording in the ACIP recommendations accordingly. Now, the plan for implementation of all of these updates is also something that we've been talking a lot about on the work group. We realized that we have to draft clear messaging in the updated recommendations. Just from the last ACIP meeting, when votes commenced on 2 pre-exposure issues, we know that there's a lot of stakeholder questions about this and what it means to them and how to roll those out. And so we've already begun discussions about how to engage with stakeholders, whether professional societies, public health veterinarians, travel medicine providers, and others, to ensure that the implementation strategies are in place and the revisions clear once the MMWR is published. We want to also ensure that the CDC Rabies website is updated and provide consultation and support to clinicians and health departments when the recommendations are published too. So these are things that we've been discussing here for whenever the MMWR is published. Now, the tentative agenda then for our June ACIP meeting is to summarize PrEP about children, the grade and the ETR again, and so that a vote can be done, and then to continue PEP presentations with the RIG and the number of vaccine dose presentations. And that will probably fill up our time. The following meeting after that can be dedicated to clinical guidance. I guess I'd be interested in any feedback about that, or whether there's any topics that you think should be addressed and were not on our agenda for presenting to the ACIP this year before we complete our work group work. Thank you.
Any comments or questions from the voting members? Dr. Sanchez, I see your hand is up.
Sorry, I did not have any questions, but I agree with what has been with Hagen's presentation. Sorry.
Thank you. Anything else? All right, I think all we have left to do is to thank you for another series of wonderful presentations. We look forward to you presenting to us again in June. We have a break now until 5 minutes after the hour when we will begin public comment. So until then, we'll allow you to have lunch or do what you need to do. Thank you.